Hey everyone, and welcome. If you're getting ready for your nursing exams, you are in the perfect spot. Today we're going to do a really high-yield, no-fluff review of two respiratory heavy hitters, COPD and asthma. The goal here is to lock in the key differences, so when you see those priority questions on your exam, you can answer them with total confidence. All right, let's dive right in.
Okay, just picture this. It's a classic scenario, straight out of an NCLEX question. You walk into a patient's room, and they are gasping for air, they look terrified, and they're using every muscle they've got just to breathe. Is it a COPD flare-up, or is it an acute asthma attack? Knowing the difference isn't just some academic exercise. It literally dictates your very first move. So let's break this down so your first move is always the right one.
So first up is COPD, and the most important word here is obstructive. Think about it like this. Getting air in, that's not the main issue. The real battle is getting the carbon dioxide out. See, because of all the damage in the lungs, air gets trapped inside, and that leads to this chronic buildup of CO2, and that is the fundamental problem we are always trying to manage.
Now, COPD isn't just one single thing, right? It's really an umbrella term for two main conditions. On one side, you've got emphysema, and we call those patients pink puffers. In this case, those tiny little air sacs, the alveoli, are actually being destroyed. This makes the lungs lose their elasticity, their springiness, and that leads to that classic barrel chest you hear about. Then, on the other side, you have chronic bronchitis, the blue bloater. And here, the problem is all about inflammation and just a ton of mucus clogging up the airways, which leads to low oxygen and that telltale bluish tint.
So let's bring this to the bedside. How are you going to spot your COPD patient? Well, they'll give you plenty of clues. You'll probably see them leaning forward in that tripod position. They're just trying to create more space for their lungs to expand. You'll notice they're using their neck muscles to help them breathe, and very often, they'll be doing something called purse-lip breathing, exhaling really slowly, almost like they're blowing through a straw. These aren't just symptoms, these are actually coping mechanisms their body has developed.
When it comes to actually diagnosing COPD, there's one number that really cuts through the noise. It comes from a pulmonary function test. We're looking at the ratio of how much air a person can force out in 1 second compared to the total amount of air they can exhale. If that ratio, the FEV1 to FVC, is less than 70%, well, that's the gold standard. That confirms there's an airflow obstruction. It's a key number to have in your back pocket.
All right, here's a classic test question for you. You look at the monitor, and your COPD patient's oxygen saturation is 89%. Now, your first gut instinct might be to just crank up the oxygen, right? But hold on. With a COPD patient, that could be a really dangerous move. This question gets to the heart of one of the biggest safety principles in all of respiratory nursing.
So what do you do? Well, it's all about following a very precise sequence. Step 1, always sit them up. Use gravity to your advantage. Then you have to remember their physiology is different. For a healthy person, a buildup of CO2 tells our brain to breathe. But for a chronic COPD patient, their brain has rewired itself. Their trigger to breathe is now low oxygen, or hypoxia. So if you blast them with too much oxygen, their brain goes, oh, we're good, and it can actually slow or even stop their breathing. That's why we always start low and go slow with their oxygen.
This quote really just says it all. You have to burn this into your brain. For your patient who lives with chronic COPD, an O2 sat of 88 to 90%, that's their normal. That's their baseline. Our goal isn't to chase 100%. It's to keep them in their safe, therapeutic range. This is probably one of the biggest patient safety points you'll learn.
Okay, let's switch gears and talk about asthma, because it's a totally different ballgame. The big difference here is that asthma is all about reactivity. The airways aren't permanently damaged in the same way as in COPD. Instead, they just completely overreact to a trigger. Could be dust, pollen, even cold air. And they clamp down hard. This reaction involves three things all at once. The muscles constrict, the airway gets inflamed, and it swells up.
When an attack is happening, the signs are pretty clear and they're definitely urgent. The classic sound, of course, is wheezing, especially when they're trying to breathe out. They'll complain that their chest feels super tight, and you'll see their respiratory rate just shoot up. And just like with COPD, the anxiety is intense because, let's be real, not being able to breathe is terrifying. A huge red flag. If they can't even speak in full sentences, you know you're in the danger zone.
Now we have to talk about the absolute worst-case scenario for asthma, which is status asthmaticus. This is not your average flare-up. This is a severe, life-threatening attack that just isn't getting better with the usual rescue inhalers. The airways are so inflamed and so constricted that the patient is heading towards complete respiratory failure. This is a full-blown medical emergency that requires immediate, aggressive action.
So let's go back to our clinical scenario. Your patient is right in the middle of a bad asthma attack. What are you going to do right now in this moment? The priorities here are different from COPD because the root of the problem is different. We need to get those airways open, and we need to do it fast.
Here is your action plan. This is what you need to do step by step. First, again, sit them upright, but unlike our COPD patient, we can and absolutely should give them oxygen right away to help with those dropping levels. Then comes the 1-2 punch of medication, a fast-acting bronchodilator like albuterol to physically force the airways open, and then a corticosteroid to fight that underlying inflammation. And you know what? Never ever underestimate the power of just providing calm reassurance. Your calm can be contagious.
But hang on, before you give that steroid, there is a super important safety check you have to do. You must ask if the patient has diabetes. Why? Because corticosteroids can send a person's blood sugar through the roof. It doesn't mean we won't give the life-saving medicine, but it does mean we have to be ready to manage their glucose levels really, really closely.
Okay, this slide is massively important, both for your exams and for patient teaching. You have to know the difference between a rescue inhaler and a maintenance inhaler. Albuterol, that's the rescue. That's the firefighter you call when the house is on fire right now. Fluticasone, the steroid, that's for maintenance. That's the fire prevention system. You take it every single day, even when you feel totally fine, to stop the fire from ever starting in the first place.
All right, that was a lot of information, I know. So let's do a quick check to make sure these concepts are really sticking. We're going to do a few rapid-fire questions. You ready?
First question. What is it that tells a chronic COPD patient's brain to take another breath? Is it high CO2? Nope. Remember, their drive is switched. It's hypoxia, or low oxygen levels. And this is the whole reason we're so careful with how much oxygen we give them.
Okay, next up, your patient is wheezing and they reach for their fluticasone inhaler. Is that the right move? No, absolutely not. That's the controller, the preventer. It's not going to help them in an emergency. They need their albuterol, their rescue inhaler.
And here's a little bonus question because you're definitely going to see this in peds. You have an infant with RSV who can't breathe because their tiny nose is completely clogged with mucus. What's your very first move? Before oxygen, before anything else, you suction. Airway always comes first. A baby can't breathe if the path is blocked.
So let's end with this last thought. We've talked a lot about medications and oxygen and positioning. But in that moment of pure panic, when a patient truly cannot catch their breath, your calm presence, your clear instructions, and your ability to think and act decisively, well, that's just as powerful as any drug. Think about that. What is your most powerful tool that doesn't come from a vial or a machine? That's something you can take with you into every single patient room. Thanks so much for joining me.